Hi, everyone. Thank you so much for joining us today for this community of practice. We are thrilled to have you all here today to hear about some incredible work towards HCV elimination with a particular focus on mental health and alcohol and other drug settings. My name is Fabi Porto, and I'll be presenting these as part of the INHSU team. But before we begin, I'd like to acknowledge the traditional custodians of the land from which I am speaking today, the people from the Bundjalung Nation, and acknowledge their continuing connection to land, waters, and community. We pay our respects to the people, the cultures, and the elders, past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. And just before we jump into the webinar, I wanted to provide a bit of a background for those who are new to INHSU. So as a quick recap for those of you who are less familiar with, with our organization, we've organized today's webinar, and the International Network on Health and Hepatitis in Substance Users, INHSU, is a global network of people dedicated to improving the health of people who use drugs. Our work is categorized across three key pillars, those being education and training, knowledge exchange, and policy and advocacy. We run a suite of programs globally across these three areas. INHSU was founded in Switzerland, and it's governed by a General Assembly, and a board in our secretariat is based in Australia. To all our endorsing partner organizations, I would like to extend our sincere thanks for your generous endorsement for this community of practice. Thank you once again, Westmoreton Health, Hepatitis Queensland, AVIL, Quiva, Quinn, and Quinada, for your ongoing support. We look forward to continuing working together. We also extend our heartfelt thanks to Queensland Government and AbbVie for its generous support as the sponsors of this event. By funding this initiative, they've helped create space for important conversations, shared learning, and collective action. Our sponsorship policy is listed up on the screen. I'd also like to thank our steering committee for your invaluable guidance, insight, and support in shaping this program. It's been a privilege to collaborate with such a committed and generous group. And as a bit of a background on how this community of practice was formed, a couple of years ago, INHSU, in collaboration with local partners, developed a hepatitis C intervention toolkit. The digital toolkit profiled a range of interventions demonstrated to enhance the HCV care cascade. So interventions such as DBS testing, point of care testing, care navigation, peer support. You can access these how-to guides for free on our website, and they're accompanied by a range of best practice models of care, infographics, and films from around the globe. The toolkit was intended for a global audience. However, we know that challenges for implementing interventions are not only going to be different from country to country, but city to city and even service to service. So we wanted to provide the opportunity for people to come together locally to discuss barriers and enablers to intervention implementation. Subsequently, in collaboration with an incredible committee, we developed a one-day in-person training program to support people to develop or enhance their own models of HCV care and build connections with other providers. The audience for this program in Queensland is highly multidisciplinary, and it's focused on staff working in mental health and AOD settings. So the program consists on the intervention toolkit, an in-person symposium, and the community of practice. These webinar series aims to facilitate a community of practice that provides a platform for discussion on any ongoing challenges and share innovative solutions in hepatitis C service delivery. We began piloting the program in 2022 in the UK and Canada, followed by the US in 2023, Portugal in 2024, and Australia this year. Since the inception of the program, we've delivered 19 symposia to 816 attendees, as you can see as per the breakdown on the screen. The audience is highly multidisciplinary, and includes a mix of healthcare practitioners, peer workers, harm reduction workers, care navigators, and program managers. We've also delivered 2 communities of practices webinars to 167 participants to date. These are the upcoming symposia for this semester, including 5 in the US, 1 in Canada, and another one in Australia in Sydney on the 4th of September. Now, I am thrilled to introduce you to our presenters for today. Amanda Armstrong, a clinical nurse consultant leading the Queensland HCV Hub. Based at the West Moreton Public Health Unit, she supports statewide efforts to improve hepatitis C surveillance, linkage to care, and quality improvement across services. Her work is grounded in collaboration and strong commitment to hepatitis C elimination. And Maxine Waldburger, an occupational therapist with almost 20 years experience working in Queensland Health, mental health, alcohol and other drug services as a clinician and manager, and more recently as a clinical improvement coordinator. Maxine, a self-professed data nerd, but not data expert, is passionate about safety and quality improvement within healthcare services and supporting all staff to harness the skills, knowledge, and attitudes that underpin continuous improvement of the services they deliver. As an overview of today, we will have 2 15-minute presentations covering quality improvement, QI-driven improvements in HCV care integration within AOD settings, followed by a panel discussion and Q&A. I will now hand over to our first presenter.
Thank you. That would be me. Hello, and just as I get started, a quick disclosure, I have actually moved jobs recently, so I'm no longer a clinical improvement coordinator and am now waiting for this to respond to me, working as a safety and quality coordinator, so still in the same league. Now, I'm trying to click across, but nothing is happening.
Did you approve control? Yes, Max?
It says I've got control.
There you go. There we go.
There we go. So yeah, thank you for the introduction. Today I've got 15 minutes and 15 minutes goes quite quick when I'm talking about something that I'm passionate about. So I will try to keep it to the basics of looking at what is quality improvement in healthcare and why is it important, and then use a simple example to demonstrate a quality improvement methodology. In this case, it's the PDSA. Most people in healthcare would be aware of the term PDSA, Plan, Do, Study, Act. It's a very simple and effective methodology for quality improvement in the healthcare sector. And then we'll just take a moment to think about enablers and challenges to cue quality improvement, particularly PDSA, in our own local contexts. So why is quality improvement in healthcare? What is quality improvement in healthcare? I hit that button quite a while ago. It just doesn't seem to be the lag for it to go to the next slide. Nope, doesn't seem to be responding.
Would you like me to take the control back, Max?
Yes.
I can help you with that. All right.
Everyone that worked on our practice run, it worked fine. So it's not that we didn't.
Okay.
There you go.
There you go.
So quality improvement, I mean, you should all know the term quality improvement, and it's kind of self-explanatory. It's improving quality and quality of care. But more specifically, when we're thinking about it, it's really a systematic approach. So it's structured and organized, and we follow process and steps. It's data-driven, so we need to measure what it is we want to change, and then we can remeasure to see if change occurs. And the intention is to enhance the safety, the effectiveness, the efficiency, equity, the patient-centeredness, all those really important things that underpin our healthcare delivery. Primarily, it involves 1, identifying a problem, 2, implementing changes to address the problem, and then 3, monitoring the results to see if change is actually happening. And most important, it really is and should be a continuous process of small iterative refinements to your practices to achieve better outcomes, as well as a more responsive health system and better professional development for staff. Next slide. Now, to save my voice, and because I don't love hearing my voice, I do have a quick little video. So this one talks about why quality improvement in healthcare is important. And I just really love the way he talks about you taking the same responsibility that we expect of our consumers to take in terms of their own healthcare. So it's only a minute long. Are you able to play that one, Fabi?
Organizations like Toyota and Bell Labs and leaders like Walter.
Gotta go back to the start. Yeah.
Hi, I'm Dr. Mike Evans, and today's talk is on quality improvement, or QI, in healthcare. So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. Something a CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook. The humility and self-awareness to say, I've got room for improvement. The ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while.
Over here, Fabi. Cool, thank you. So as I said, love that little video. It's kind of just calls out that we ask our consumers to consider their situation, think about how they can improve, what changes they can make, and then make those small iterative changes over time to hopefully have better outcomes for themselves. And if we expect that of our consumers, why would we not do the same ourselves as individual clinicians, but also as teams and services? So there's so many models around the world for quality improvement. But we're talking about healthcare improvement. And one of the leaders in healthcare improvement is INHSU, and they have the model for improvement, which is, I think, your go-to first step for someone who's new to quality improvement in healthcare services. And that's the Plan, Do, Study, Act methodology. So we're really looking at answering 3 questions when we're thinking about improvement at any level. First of all, what are we trying to accomplish? How will we know that a change is an improvement? So what will we measure? And then what change can we make that will result in this measured improvement? And it's, as I said, it can be as simple as you like. You probably do PDSAs, or you do PDSAs in your own life every single day. You might get up and think, I'm going to have some cereal for breakfast, and you open the fridge and the milk's out of date. And you're like, oh, well, I can't do that. I have to change something, So you make a change, and then you apply that change and move forward through your process. So we're changing our approach all the time. But I have an example, Barbie, next slide, to walk through just to show the application of the PDSA. Really simply, I've decided to use a very different example that's not healthcare related, but something that we can all probably relate to, which is an example for baking cookies. And so the template that we've used is just a typical PDSA template, and there's links to it in the resources, but it breaks down this activity into these steps. So if we start with plan, when we're baking cookies, the project aim or the plan is to create a consistent biscuits from scratch. It even determines how you want them, flaky on the outside and fluffy on the inside. So the objective is to determine the best method for doing this. So we start with the first cycle, and part of the plan is to have some questions or predictions or plans, and that might be based on the recipe you got from taste.com, which says to cook the cookies at 400 degrees. And you're going to measure it by tasting the cookie and looking at the colour and noticing the texture. So that's you've written down what your plan is. The next step, which is the next slide, is to do it. So the do is really easy. You just do the plan that you wrote down. But it's also really important, as you can see there, the hint is to record what happens as you do it. So what happened in this case is that the cookie was cooked for 15 minutes at 400 degrees, and the result was hard on the outside, thin inside, not much fluff, taste not good. So they've got the do and they've collected the data. We'll go to the next step on the next slide, which is study. And studying is really about looking at the data that you collected and comparing it to that original prediction or the aim even. And what did you learn? So in this case, yeah, the biscuits were too thin. They weren't fluffy. They didn't taste very good. That's not actually what we were aiming for. So we need to think about what are we going to do to change that, to improve it. And that's when we move to the final step, which is act. And with act, we talk about whether you want to adapt, adopt, or abandon. So we're sticking with that alliteration, all the A's. And at this point, you might say, okay, I got it wrong, but I think I can make a small change and get it right. So in that case, you're probably adapting a little bit. If you had it spot on, you've measured what you did, you collected the plan, the steps you took, you'd say, okay, I'm going to adopt this. It's perfect. Or maybe you just had enough. You hated it. It was horrible. You don't even want to try again. So you're going to abandon it and try cooking pizza next time. But in this case, the plan was to adapt. So decided to add more whipping cream and make a bigger biscuit shape and cook it at a lower temperature. So those modifications feed into the next cycle of a PDSA. So you look at the next slide, we've completed one full cycle. We're going to start a second cycle. This is your next iteration towards doing something, measuring it, and then assessing or studying whether it's actually achieved the outcome you wanted. So we can apply this very easily to any kind of healthcare change, as long as we keep the goals really small and simple. And one thing to remember is PDSA is continuous quality improvement. It's small and it's iterative, and it's not to be confused with large implementation science or knowledge translation projects that are big pieces of work. So this can be done by a team or an individual very easily, but there's a lot more resources available around how to take these steps if you need them. Now, next thing to think about when it comes to quality improvement is, we have the resources available online and there for you to help you, but is your service actually ready for change? And when we talk about ready for change or change readiness, it's about the context where you are at the moment and the willingness and ability of not just you or your team, but your service. Do you or your team and service have the psychological preparedness and practical capability to really work through this kind of change? It's about embracing new thinking, innovation, transformation. And so it's really important that before you go, okay, we're going to do quality improvement as a team, you really think about whether your team is ready and has all those crucial elements for success and readiness to change. Once again, there's a lot of research and literature around readiness for change, which I suggest you have a bit of a look at if you are keen to undergo a QI journey. But I thought we might today just have a really quick interactive discussion, or at least throw in your thoughts about your context. So Fabi's going to bring up a poll. So the first question here, so if people can just randomly submit some answers. What are some of the enablers of quality improvement that you experience in your workplace? So what are things that support, promote, enhance, encourage, inspire you in your workplace or enable you to be able to do quality improvement? Starting with the positives. Where will the answers come up, Barbie?
I'm just waiting to hit at least 10 answers. We've got
Okay.
8. Yes.
Ooh.
But if you're happy for me to stop the poll right now, we've got 10 answers. Would you like me to show the results?
Has everyone written something in? If you've written something in, yeah, we may as well bring it up for time's sake.
Yep. Okay, there we go.
I don't.
No?
No, I'm just seeing the poll. Still just showing the questions. Oh, here they come, I think. Oh, it's a word cloud. Great. So we've got staff, engage, team, leadership, progressive unit, awesome, supportive, systems, collaboration, peer, director. Yep. So lots of different things. So I can see there's person characteristics, so people, but then there's also kind of system characteristics. So I'm seeing things around the word systems. So, yep, that looks really great. Does anyone have anything that they wanted to add to that? Oh, yeah, Bobby, we can move to the next one. So there's a lot of research as well around enablers of QI in healthcare, and you've touched on quite a few things there. The top one usually being strong leadership. Can I just have 2 seconds? I can't come to the door right now.
Oh, sorry.
Sorry, I've got someone knocking at my front door. Good timing. The other thing is continuous learning culture. So this usually comes from leadership, but a culture around that continuous learning and change towards improvement. This goes along with a restorative just culture within the organisation. So we have the willingness, I guess, to look at errors or mistakes or things that didn't go well and analyze those for improvement purposes. And then we have some of those really obvious ones like money, as well as technology and tools, all really almost the foundation in this day and age. Capacity and capability, so workforce development are really big ticket items as well. So not just having the skills, but the time set aside to do QI is really important. And then consumer engagement. We wouldn't be able to do great QI and improve our services for the consumers if they weren't involved in the process. So things to think about when you're thinking about your services readiness for change or QI. Now we're going to do the flip and we're going to do a quick poll thinking about the challenges that you might experience in quality improvement in your context. And a little hint that it might just be the opposite of the enablers. You want to pop that poll up? I imagine we. Yep.
Sorry, Max. I was
That's
just
okay.
going to say that we just hit 10 answers now.
Let's have a look at the little word cloud. Oh, great. Just what I expected. So lack of time. We've got, I'm assuming, lack of resources. I'm assuming it's lack of enthusiasm. Yeah, so staff. I can see the word lazy there. That's blame. Yep, so the opposite of a restorative just culture. Often it's just about blaming people rather than thinking about what can we do differently. So yeah, that's if we look at what the research says, once again, lots of different research, but we look at a bit of a meta review of healthcare quality improvement. Obviously, the inverse of the top enablers, we've got resistance to change. So a culture from leadership that's really resistant to change. And this is often not just change in like processes, but change when it comes to technology. It's becoming a big thing today that a lot of our improvement is technology based. And there are a lot of leaders who are in the older generations who are a little fearful of that. So we've got inadequate resources is right up there. Lack of data. So we're becoming this like data rich and data informed society, but we're still catching up with our use of data. So how do we make the best out of understanding the data and using it for future decision making? Poor capacity and capability, direct inverse. If we don't have staff that are trained or have the tools, it's not going to happen. And then also link into leadership are the next two. So structures and processes, and that's often around governance and accountability and follow through. And then we have system complexity and change fatigue. So there's so much top-down change being pushed on us all the time in healthcare that sometimes we just can't even find the energy to do some bottom-up quality improvement. So that's probably all I'm going to cover today. So, quality improvement is important. We have methodology available. There's tools all over the internet nowadays. You should all be having access to data that you can use. So then the final step for you really is, where's the readiness at in your team or service, and what can you do if there are challenges? In terms of the readiness, what can you do to mitigate that and maybe shift your team into an area of readiness for change? Are there any questions?
That was excellent, Max. What I would encourage people to do is either pop questions on the chat box for now, or just wait until we open the floor for Q&As after Amanda's presentation, so we have a bigger group discussion. Would that be suitable for you, Max?
That would be perfect.
Amazing. So feel free, everyone, to put down your questions on the chat box, and we can have a look at these once we finish the next presentation. And I'll bring on Amanda, and will just double check, Max, that your slide control is off.
All right, it looks like I've got control.
Amazing. I was just going to ask you. Thank you
Let's
so
give it a
much,
go.
Amanda.
All right, thank you for the opportunity to speak today. I'm going to talk about clinical auditing and using that PDSA to drive a clinical audit, using an example of streamlining reception to Hep C treatment in a prison setting. This has got a bit of a lag too, Fabi, if you wanted to take back control to keep things moving. Yes, so I'll be talking about clinical auditing and that PDSA cycle, using the example of how we could streamline Hep C screening to treatment that we did as a clinical audit. Thanks. So what is clinical auditing? So by definition, it's a quality improvement activity designed to improve patient care and outcomes. It's a systematic review of aspects of clinical performance against explicit predetermined criteria and the implementation of change when the results indicate standards aren't being met. So why would we do a clinical audit? The clinical audits are done to improve the quality of care and patient outcomes, to identify gaps in care and improve equity of service delivery, to identify and minimise risk, waste and inefficiencies, and to provide assurance of compliance with clinical standards. So I'll go through a clinical audit that we've done. This was back in 2017. So I just wanted to set the scene. This is very early in the rollout of Hep C treatment in prisons. Prison health staff were getting really frustrated by the inability to complete the treatment workup and start treatment before people were released or transferred. Prior to this clinical audit happening, a system mapping process had been conducted to map the patient journey from reception interview to treatment, identifying key drop-off points along the way. So it wasn't the first PDSA cycle that we'd been through. As Max pointed out, this is an iterative cycle. Thanks. So when we're planning a clinical audit, first thing we need to do is figure out what we're aiming to do and what the scope of that audit is. So as Max said, start small, look for your low-hanging fruit. And I think if you think about your own service, there's often things like, if we could just fix this one thing, the rest will flow on nicely. So look for those key things, and maybe that's what you want to focus your clinical audit on. When you're defining an aim, make sure it's SMART, so specific, measurable. How do we know that a change is happening? Is it attainable? Is it relevant? Is this actually worthwhile doing? And is it timely? Can we attach any sort of urgency to this? So the clinical audit, so the Westmoreland Health Project, the project objectives were to elucidate the current screening, assessment and treatment cascades in the prison centre, determine baseline rates and outcomes of Hep C reception, screening and assessment, identify any gaps in the care within that treatment cascade that we could fix with the quality improvement intervention, and implement that quality improvement and assess the impact with the follow-up clinical audit. You'll notice that a lot of these slides are still in the planning phase, and that's on purpose. The more planning that we can do and get right from the beginning, the better the clinical audit's going to be. The next thing we're doing while we're planning is engaging with our stakeholders and securing resources. So the more we can communicate, the better. So all through the clinical audit, all through any quality improvement, the more input you get from staff and leadership and patients, the more buy-in you get, the more ownership you get. Clinical auditing is a skill in itself, so make sure you get the required expertise from the beginning. A lot of HHSs will have a quality unit that will be more than happy to help you out with planning an audit. You might need to talk to your research and ethics team. You definitely need clinical team on board because they know what's happening on the ground. IT system team could be helpful, and we'll talk about that a bit more, and leadership. And that's important because we need to ensure adequate resources. So it's very unlikely that we're going to be able to complete a good clinical audit in BAU with your current workload. So you're going to likely need protected offline time to complete the audit. Look at whether actual funding is required and whether people that are completing or doing the data analysis of that audit need additional skills and training. So in our audit, our stakeholders were, we go back, Barbie, prison health nursing staff and management. They were on board. This was a need they identified themselves. The public health team, so we had a doctor, nurse, and epidemiologist, which is fantastic for data analysis. And we went through an ethics and research team. For resources, there was in-kind support from both public health and prison health service staff, and then we received a small research grant from the Westmoreland Health. Thanks. Can we go to the next slide, Barbie? Thank you. When we're planning an audit, we need to select explicit evidence-based measurable criteria. So we'll break that down. So when we're looking at what criteria we're going to measure, we need to make sure it aligns with Australian and Queensland Hep C guidelines. So for example, we wouldn't be trying to see if we can get a test of clearance or an SVR as soon as possible after treatment. We want to make sure that's an SVR4, so that's evidence-based. We're looking at different measures. So we've got process measures which look at, does the process work? And outcome measures which show are patient outcomes improved. So if we look at in the purple section, these were the measures that we were trying to get, the criteria we are assessing. So we're working our way through the Hep C care cascade, looking at who consented, how many people consented, were their bloods ordered, were those bloods actually collected? So they're all process outcomes. So process measures, whether the person had a past or current Hep C antibody test is an outcome measure, whether an RNA test was done, that's a process measure, whether an RNA was detected, the outcome, so on and on. So what we want to do when we're in that planning stage is basically write your results section, not with the data in it, but plan what you're going to do, what tables you're going to use, what data analysis you're going to do. So for our project, we wanted to see numbers moving through that cascade as well as time. So the time from consent to bloods being ordered, time from bloods being ordered to bloods being collected, etc. So my little red textbook, don't just record it, plan to report it. And it rhymes because it's true. So if you can write and work out your criteria at the very start, what analysis you're going to do. Another thing we wanted to do was make sure that there wasn't patient characteristics that were impacting on their movement through the cascade, like was only really young people moving through quickly? Did Indigenous status impact people's movement through the cascade, or length of sentence? So make sure that we collect those things that we want to analyse. All right, next slide. So once we know the criteria, once we know what we're going to analyse, then we can plan our data collection. So we need to look at what data sources are available to us. Can we link any data? So that's where it's really good to have someone with IT system knowledge on it, on your team. What information can be pulled straight out of SIMA that you wouldn't have to actually manually review every patient's chart to find. Look at what timeframes you want to audit. So in ours, we did a whole month in early 2017. Who will collect the data and how? So we use a data collection tool, and public health nurses did the audit. How will you ensure data quality and consistency? We did a validation of the audit tool, and I'll talk through that a bit more, and minimize the number of collectors. So the more consistent we can be, the better data quality we're going to have. Look at what your denominator is and your inclusion exclusion criteria. So our denominator was all new receptions, but maybe if you're trying to focus on a group of people, you might just do that group. And consider if there's any privacy, consent, or ethics considerations. So our project went through a Westmoreland HREC review. Next slide. All right, we're finally doing the audit, but once again, a lot of these dot points actually come back to the planning part, but I didn't want to put them all in planning. So, all right, we're conducting our audit. When we're doing that, we need to be systematic and consistent. So use a standardized tool or form for data collection. Clearly define what counts as meeting criteria. And so if we're saying that appropriate testing was ordered, yes or no, clearly state what appropriate testing is. So when people are collecting that information, they're all collecting the same thing. And that will be through creating a data dictionary and like definitions for each parameter, and providing training and support for data collectors. Pilot the tool, make sure it's fit for purpose. Standardize fields as much as you can. So if there's a yes or no, tick box, avoid free text, because people try and put as much information as they possibly can into free text fields, and then you end up having to recode it later. So if you can try and do standard options. And when you're piloting the tool, if you find an option that you want to keep putting in and that's not there, that's a good time to add it in before you do the full audit. Keep it simple, only collect what you're going to use, and we know that because we've already planned our data analysis, so we know that there's fields that we won't use, so we don't need to collect them. Make sure you're sampling appropriately. If you're doing a large volume, it might want to do some random sampling or try and get 100% if that's actually feasible. Record non-compliance with criterion clearly so we can work out why people aren't getting, process measures aren't being met, things like that. Maintain confidentiality, so we need to protect identifiable patient and staff data. So when we did our audit, the data collectors audited 30 receptions, so 30 chart reviews, and there was overlap in those, so we could compare what people were collecting. If there was people were collecting different things for the same person, we could amend that collection tool or provide some extra training. Our sampling was a month of receptions into prison in early 2017, aiming for 100%. Only people whose charts we couldn't access were excluded. And confidentiality, so electronic files were password protected. We're using Westmoreland Health servers and making sure that identifying information was removed from the collection form. So a good amount of thought went into how we can protect people's data. Thanks. So we're going to do the study part, so PDSA study. We need to compare how we did versus a criterion. So if we're wanting 100% of our patients to be offered testing, how many were? So how did we compare against that 100%? Analyze patterns in non-compliance with process outcomes. Quantify and describe the gaps. Use simple visual displays. It's much easier to look at a graph than to read a lot of text. Incorporate qualitative feedback. So a nice starting point when you're looking at a quality intervention is just to figure out who in your service is actually due for a Hep C test. But how easy is that to do, and how often could you actually do it, and looking at how much work that requires. So that's all qualitative feedback. When you're looking at your data that you've collected, consider the accuracy, completeness, and how much it represents your clientele. And consider the implications, and then summarize those key findings. If we go to the next slide, this is the baseline audit. So we're looking at the characteristics of the women entering prison. I'll just pull out a few points. So 81% stayed for less than 6 months and 30% stayed for less than 1 month, which really showed that whatever we were going to do, we had to make sure it was a streamlined activity to catch people while they were still there. 25% reported Hep C at reception, so we needed to make sure that we were accounting for that and making sure there's options that weren't where we weren't repeatedly doing Hep C IgG testing because they already knew that they've had a previous infection. And 33% Aboriginal Torres Strait Islander people, and 10% were overseas born. So we need to make sure that people from minority groups were moving through equitably, so as much as the general population. Next slide. So we captured the process and outcome steps in a cascade of care. So if we start from the very beginning, our total study population was 110, so that's 110 charts that were reviewed. Of those, 67 consented and were tested. So we've got a gap of 43 that fell off between reception and getting tested. Of those, 34 were antibody positive, so evidence of previous or current infection, but we need the RNA test to be done to confirm current infection. So of the 34 people that should have got an RNA, 16 did, so we got a bit of a drop-off there. Of those 16, 11 were RNA detected. Of those, 2 were eligible for treatment and 1 commenced treatment. So I just want to point out this is very early in the rollout, and at the time, you had to be incarcerated for your whole treatment duration and SVR 12. So you had to have at least a 6-month sentence before you were able to start treatment. But if you could just have a look at that data, so we're studying this and we're looking at what our next PDSA might be. What are some really low-hanging fruit that people can see? You can add it to the chat or call out where the gaps are shown in that dotted line. What easy interventions could we do to address some of these? Call out anybody.
I can see in the chat why are people not consenting, and that was my first thought, step 1 to 2.
Yeah,
consenting.
So is there a quality improvement we could look at for consenting? Is it an education thing? Do we need to unpack that further? Yeah. Any other ideas? Yeah, that's another. So do people not trust confidentiality? So maybe that's something that needs to be put into when you're requesting informed consent to discuss where their information goes and who receives it, and it's not Queensland Corrective Services, that kind of thing. Reflex testing, we see if we were able to reflex RNA testing straight after antibody testing, we could get that number from 34 antibody positive to 34 people RNA tested. Yeah, so that would cut out a big gap. And then looking at eligibility for treatment.
Yeah.
All right, thanks, Fabi. We'll move on to the next one. So acting, we need to use the information that we're collecting. So first thing, communicate, celebrate, and continue. So make sure we're sharing our results with the team, including leadership. Very hard to argue against doing a quality improvement activity if your data demonstrates a real issue. Acknowledge and celebrate the people that contributed and the work that they did, and celebrate where things are going well. I know that 67 out of 110 might not look like a great consent rate, but when compared to the international literature at the time, it was pretty good. So that would be something to celebrate in this situation. Adopt, adapt, or abandon. So if we're looking at our clinical audit tool, did the audit capture what it needed to, and what changes are needed for the next audit? And then start the PDSA cycle again to plan the quality improvement. So based on this data, the quality improvement activities that were created was the implementation of a clinical pathway to standardized processes, and implementation of reflex testing and treatment workup bloods following a positive hep C antibody test. The audit tool was tweaked to enable capture of the new process prior to re-audit. Thanks. So the takeaway messages with clinical auditing: start small and stay focused. Let the data guide you. And audit's about progress, not perfection. So the purpose of an audit is to find areas where we can improve. So it is going to demonstrate problems, but don't focus on those. Focus on using it to progress and to move to the next PDSA cycle. Thanks, Barbie. There's some references there. I just wanted to highlight the first one. ASHM has a clinical auditing and case finding in hep C education session that's you can do when at your own pace. It's really good for people working in primary care to be able to identify people with potential hep C in their practices so they can follow those up appropriately. Thank you. That's me.
Mhm. Amazing, Amanda. Thank you so much for this wonderful presentation. Well, what I propose us to do now is to come to the Q&A session for about 10 minutes. And I can see there is nothing else added to the chat box. Is there any particular questions you'd like to ask Amanda, Maxine?
Yeah, I have a comment and a question, if nobody else does. So I just, first of all, thank you for using a lovely PDSA example to illustrate what I kind of started talking about. I did want to make a comment to people. That was a really, really awesome example, but it was big. Hence your planning, you had a lot of slides around the planning. So it was lovely, but don't be daunted by it and don't feel like you have to do something that big to start with. If you're new to PDSA, start small. If your service doesn't have a huge readiness, start small and build that momentum and engagement. But Amanda, because I've got this awesome background and you've got me thinking about what you've done and implementation science, you've made lots of little changes through your audit. So which specific kind of changes do you think had the greatest impact? And what would you, recommend other people focus on?
So without a doubt, implementing reflex testing. So once that was implemented and we did the re-audit, it improved people moving through that cascade significantly. That was the biggest change. So very low-hanging fruit that the data showed us, and that was one of the things that we implemented.
Mm-hmm. Awesome.
That's really good. Does anyone have any other questions for Amanda's presentation? And in the meantime, while you're thinking about it, I just suggest that we flick and check if Amanda has any questions for Maxine.
Yeah, sure. You went through the enablers and challenges of quality improvement. If you had to just pick one enabler that makes the biggest difference and one that staff could advocate for, what would it be? You're on mute, Max.
I feel like from experience and looking at lots and lots of teams, what I see is leadership is the biggest enabler, but it doesn't have to be leadership from the very top. it has to be a leader. So often if a team leader is really focused on improvement, the team will be positive and continuous improvement kind of focused, but it doesn't even have to be the team leader. So often it's a CNC or a senior clinician who just has that drive and energy. So that really for me, it's just a leader.
Cool, thank you.
Yeah, that's such an important message. And what I can say is that there aren't any more questions on the chat box, but I'll give you guys a few more minutes just to think about if there is anything that you'd like to ask the experts, as I'll just move through a few final slides for INHSU, and you can just pop it on the chat box, or we can just check again if there is anyone that would like to unmute themselves. But just in case, if you're not an INHSU member just yet, and if you'd like to become one, there are a range of benefits such as discounted registration to the conference, which this year will be taking space in Cape Town. So if you're interested in signing up, you're welcome to scan the QR code on the screen. And if you also need some more information in how to join, you can always jump on our website and just have a look at what's available. We would also love to hear the feedback for this session. So the first QR code on the screen is related to this particular webinar, and it is a lovely way for us to hear more about your likes and dislikes. So it would be really great if you could just scan this QR code and just go through the post-webinar survey. That would be super helpful for us. And exciting news, we've got a next webinar on the same topic for the Queensland program happening on the 12th of September, featuring different case studies and different presenters. And this is also with a focus on mental health and alcohol and other drug settings. So you're very welcome to use the second QR code on the screen to register yourselves, sign up, make sure you've got your seat allocated. And this is going to be the wrap up of these a series of communities of practices related to the Queensland program. So I'll just leave this on the screen just for a second, checking if there is anything coming up on the chat box. Nothing else at this stage, but just giving you a chance to scan both QR codes if you're interested on the next webinar, and also giving us your lovely answers for the survey. And please don't stress if you can't scan these right now. A post email will be sent as well. So lastly, I'm also thrilled to share with you more information on the upcoming National Community of Practice to improve Hep C outcomes for people who use drugs in regional and remote areas. This project is delivered by INHSU in partnership with Burnett Institute, which is also the funder, and will consist of a series of webinars delivered between November this year and early 2027. For more information, please head to our website or scan again a QR code. And this QR code will give you access to the website and everything that pertains this community of practice. So these will be guided by a multi-stakeholder steering committee, and we're aiming to deliver about 6 communities of practice in the format of webinars. So if you've got any questions, if you're interested in being involved in whichever shape you would like, please send me an email, so fabiana.porto@insu.org. And we'll be very happy to go through any questions or any thoughts you'd like to share with us for this community of practice. And this brings us to the very final stage of our presentation. And we've got a lovely feedback on the chat box. Thanks, Maxine and Amanda. Really informative presentations. We do have about 5 minutes or so, and I would love to hear more thoughts or make sure that everyone here has their questions responded. Take advantage of these amazing presenters that we have here today, just waiting for your questions. Does anyone would like to volunteer to unmute themselves and perhaps just bring in 1 or 2 questions. Okay, Sarah is complimenting us, gave some great ideas to contemplate. And I can see we actually have some of the next webinar presenters in this room. Any comments or thoughts? Lisa Ball?
Hey, Phoebe.
Hi, Lisa. Welcome.
Thank you. Sorry, I've got a bit of a cough.
Would you like to share any thoughts, Lisa? Lisa will be one of our next presenters for the next webinar.
Not at the moment. It's given Grace is here with me at the moment. Just given us a lot to think about, different plans and processes that we're putting in place at the moment. So just really gave us a little bit more information to be able to wrap up what we're doing.
Mm-hmm.
Thank you, ladies. It was amazing.
Thank you.
Lovely. Okay. Well, it seems like we've got a pretty straightforward presentation as no questions came up. This is it's a positive aspect, I'd say. But if you do have anything else that comes to mind later on, please don't be shy to send us an email if you'd like, and we can direct your questions to the presenters as well. I'm not sure if presenters feel comfortable to share their professional emails on the chat box, and if people would like just to directly contact them, feel free to do so. And if you have no further questions, if nothing else is coming up, thank you so much, Maxine and Amanda. You're amazing. They just shared with all of you their contacts. So another opportunity for you to draw in from the expertise of these two lovely ladies. And this seems to be our wrap up for today and for the first session. And I would love to thank you all again for coming up. What I will do, just as a wrap up, is just make sure that you all know that this particular session will also be sent as a recording. So if you do have anything you'd like to go through again and double check the slides, we will be sharing the recording of this meeting. So thank you so much, everyone, and have a lovely weekend ahead. We'll see you all next time on the 12th of September for webinar number 2.
Thanks for the opportunity.
Thanks,
You're
Barbie.
very welcome. Thank you very much, everyone.